and the failure of treatment. Now I want to talk about treatment in schizophrenia. As Meltzer said, there is a 30 to 50% of resistance to antipsychotics. We know that there is at least 30% resistance to antipsychotics. Clozapine is also about 30 to 50% of antipsychotics. So we can say that including clozapine, there's a 10 to 20% resistance to all treatments. Let's look at this very carefully. We know that in 5 years, 80% of schizophrenia patients come back as a patient again, and every time it's very difficult to treat these patients. When we look at the functionality and psychotic attacks, we see that prodrome is a lack of functionality. Schizophrenia is a disease that becomes chronic in time and it becomes more stable. In the United States, about 10% of schizophrenia patients can work and can function. So we know that about 10 to 20% of the schizophrenia patients are resistant to treatment. A full cure in schizophrenia is about 15 to 20%. Actually, the real resistance to treatment is 80 to 85%, and so maybe even 90%. Why do we have resistance to treatment? There are many different factors related to the disease, and there are also certain factors related to the treatment. I will be talking about the second part. Is early treatment important? Yes, early treatment is very important because we know that in the prodrome period of the schizophrenia, before psychosis, in the brain there are certain transformations going on. The Australian Melbourne group indicates this very carefully. We know that in consecutive years, when you take MRI from the patients, you will see that certain structures are becoming less and less important. In the schizophrenia patient, there is a neurodegenerative process, and this process continues according to Thompson. Here you see the MR results of the patient in 5 years. Every year a patient is losing about 5% of his tissues. This is a newer study. I like the colors, that's why I want to show it to you. This is a Spanish study. In the frontal and temporal lobe, there is a serious tissue loss. Biological modifications and loss of functionality happens starting in the prodromal period. During this period, antipsychotics may have a positive impact on the brain. Some animal studies seem to indicate this to be so. Maybe in the early period, neurodegeneration could be prevented. In the early period treatment in the prodrome or after psychosis. How do we define prodrome in schizophrenia? There are many definitions, but prodrome is a period where psychotic indications are weak or when they are limited in number, and if the individual has lost his functionality in the recent year, then this is in the prodrome group. There are many studies which have tried to measure the period of prodrome. About 36% of the prodromal patients have progressed to psychosis. Different treatment modalities are available. Ziprasidone has been tried in the United States, but it has not yet been approved by FDA. McGorry and group in the PACE clinic in Melbourne have carried out a risperidone study. They give risperidone during the prodrome period, and at the end of 6 months they see that there is a significant difference between the patients who are treated and who have not been treated. At the end of 6 months they stop the treatment, and they see that in 1 year risperidone group is less sick than the other group. The Yale group have studied olanzapine 8 milligrams. The methodology of the study is very carefully programmed. It's a double-blind study. It's a olanzapine versus placebo study. At the end of 1 year, those who have psychosis with olanzapine are 16%, whereas in the placebo group, the psychosis patients are 37%. Olanzapine group have been studied at the end of the second year. The rate of psychosis is also increasing. To stop psychosis, you have to continue administering the medication. A German study based on different criteria, amisulpride for 120 milligrams. Amisulpride is effective for functionality and also depression. Another open study with aripiprazole, 5 to 15 milligrams. There is an improvement at the end of the first week, and in 8 weeks there is no progression to psychosis. And here you see the psychotic indications. In the United States, in New York, Goldblatt and colleagues have many publications. They are asking whether antidepressants can be used to treat the schizophrenia prodrome. In the antidepressant group, the results seem to be better, but they are comparing apples and oranges. In the antipsychotics group, there is a disorganized approach. There's also a poster about the effects of lithium. We have also heard that schizophrenic patients have less essential fatty acids. EPA may be useful here. It increases NAA and decreases glutamate, and therefore it decreases oxidative stress and apoptosis. Here a study that has not yet been published. 76 prodromal patients, one group, received 1.5 grams of EPA, the other group did not, and there is a significant difference between the two groups in progression to psychosis. But the number of patients are limited here. PANSS and GAF scores indicate a significant difference in the EPA group. The results are better. That's another new study here. 2 grams of EPA was given to 2 groups of patients. The patients are taking their antipsychotic drugs as well as EPA, and response is more rapid, and the psychotic dose is less, and also constipation, EPS, and sexual side effects are less. In MRS, in the central nervous system, glutathione and glutamate have increased, and the increase in glutathione is highly correlated with negative indications. They have used the EDIE here. In my opinion, the cognitive treatment in prodrome is the most important study. It's a 6-month study. Schizophrenia patients have received the cognitive treatment for 6 months, and they followed them very carefully. In the treatment groups, progression to psychosis is 6%, whereas in the other group it's about 20 to 30%. At the end of the first year, the results have continued and the benefit has been preserved. You can see this in graphic form. Same group in 2007, at the end of 3 years, has published an article where they say that at the end of 3 years, cognitive treatment seems to be less effective. But still, there are less antipsychotic prescriptions in the prodromal cognitive treatment group. The cognitive treatment is having an impact on positive thought process, and the objective is to modify the thought process. Therefore, cognitive treatment may be highly effective. The Cognitive treatment in prodrome has also been studied in Germany, but they have not come up with any positive results. Let's say that prodrome is over, the patient is already psychotic. How do we decrease this duration of untreated psychosis? It is defined as DUP. DUP is the period between the period until the patient is prescribed antipsychotics. In most populations, it's less than 1 year. In some populations, it could be 3 to 4 months after diagnosis. The first article about DUP has been published in 1990 by Wyatt et al. It's about neuroleptics and the natural course of schizophrenia. Neuroleptics, when they are given at the first attack, may have a positive impact on long-term prognosis. Neuroleptics, when you stop it in stable patients, the patients will not be able to go back to previous level of functionality. The results are also in harmony with ECT. Schizophrenia after neuroleptics in the 20th century is a better prognosis. Catatonic and hebephrenic patients have decreased, and therefore early treatment may have an impact on the progression of the disease. In the acute period, if there is no treatment, then relapse will be increasing. In 2005, there was an article about relationship between duration of untreated psychosis by Perkins and the other is by Marshall. It's the relationship between DUP and response to treatment. All these studies indicate that on the right side there is long DUP with the worst result, whereas short DUP is a better outcome. Is short DUP better or not? Naturally, as you can imagine, short DUP period is better for the patient. As the DUP period is lengthened, the response to treatment is worse. The two meta-analyses indicate that short DUP period will decrease positive and negative indications and will get a better response to treatment. But the effect may vary from patient to patient. After 2005, there are several studies. One of them is a study by Dr. Alp from Turkey. If DUP period is lengthened, then the patients will have unacceptable social functionality. They will have less positive indications and social functionality will decrease. As DUP is longer, the hospitalizations increased. Early remission is the most important factor here. In recent years, we are trying to understand the impact of short-term effect of the drug. Let me also show you some gray matter abnormalities related or associated with duration of untreated psychosis. So long-term DUP is correlated with loss of gray matter. It's also related to white matter loss in male patients. Late dyskinesia and resistance, that is also important. In our daily practice, we don't take it into consideration, but we must realize that if in the initial episode, if there is delayed dyskinesia, it may mean that the patient is not responding to treatment. Maybe in these patients, we can start with clozapine. Dr. Kazım also said that in deficit syndrome patients, you have to be very careful. How do we prevent resistance in the early period? What are the protocols? There are certain protocols, such as serious intervention programs, and at the end of 2 to 5 years the patients have been evaluated. It was published by Bertelsen in 2008. The need for antipsychotics is less, hospitalization is less, and the patients can live independently. But when the program ends, the positive impact is also lost. We also realize that there are additional treatments such as social functionality, etc. In summary, we can say that in order to prevent resistance, you have to diagnose and treat psychotic patients as early as possible. Try to prevent relapse if possible, but you must not give too many drugs to create side effects, because the patient will be non-compliant and will lead to relapse. Clozapine treatment should be started early. If you see any resistance to treatment, if there are any negative indications, or if the patient is non-compliant, and non-compliance is indeed a very important factor here, in that case you have to think of clozapine. Psychosocial, community-based studies also should be integrated. If you are interested in the subject, you can look into the Cochrane review. There was a review published in 2009, and you can study it. Thank you very much.